Welcome to the PODdoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And we get emails and texts from some of our subscribers, and we got one the other day talking about.
It was appreciate an episode explaining second bunionectomy versus great toe fusion and when to consider these procedures. So we took it as second bunionectomy, assuming that you've had one bunion procedure done in the past.
Kind of a redo.
A little revision. So let's dive into that. So bunions after having bunion surgery, right? So we already talked about what a bunion is, right? It's a subluxation or deviation of the bone. Your bone is drifting and your big toe is subluxing on that joint there. The surgery is to, go fix all that.
So, correct. You're trying to correct the position of the joint. That's the goal of the surgery. And I think most bunion surgeries that fail, it's a failure of the choice of the bunionectomy.
Yeah.
For the most part. Would you agree?
100%.
Yeah. So, there's 14 different ways you can fix a bunion.
There's actually
100.
Yeah, there's like 100 plus different ways, but there's
40 realistically, there's
common.
Probably like 8 to 10 that are commonly done in 2024.
Yeah.
And of those, you have to develop your approach based on what you're seeing clinically, and so trying to match the surgery to the patient, obviously.
Yeah, and there's pros and cons of each. There's no
Absolutely.
one fix, for all bunions.
But there's always a better one. So, I think in today's parlance, if you're doing a bunion surgery to address a severe bunion or a very hypermobile bunion, the lapidus bunionectomy or some of these proprietary names, lapiplasty, where you showed back in that previous slide, the fusion, far bottom right one, that's become very popular for these severe bunions.
Yeah.
And if you don't address that instability site and you fix the bunion out at the joint level, you're going to end up with a certain percentage of people who are just not happy with the bunionectomy.
Yeah. So these are the three most common that we see right now as being very, very popular. There's, like I said, there's dozens of different versions. There's what's called a Austin-Aiken bunionectomy or a long arm Augustin, which is a Kalish. What we do is we do a little distal osteotomy. If you can look back at our previous episodes, we've talked about this. And a lot of times we'll do what's called an Aiken along with it to help realign the distal end of that toe joint to be parallel with the IPJ, the interphalangeal joint here. So hopefully, toe looks nice and straight.
You've realigned the joint, obviously. Now, what you don't see with those two views is the lateral view. So if that lateral view or the side view of the foot showed that the first ray was elevated, that may have been a patient who had hypermobility and that wasn't addressed. And so you wonder down the line, is that someone who's going to be happy with it? Yeah. Now, if that was purely transverse deformity and there's no elevation of the metatarsal, that's probably going to be a long-standing solution. They may not ever have problems with it.
Yeah.
You can have, like in your upper right hand.
Yeah, you can have small bunions like this, but it'd be hypermobile.
Right.
And have to do a lapidus
Or
bunion.
at least consider it. And if the patient can't be in a cast, can't be on weight bearing for several weeks, sometimes we compromise and we say, well, we can fix it up at the joint level and not fuse your first metatarsal cuneiform joint. But we're not addressing all of the deformity, so that's where we would use orthotics, custom arch supports to try to lock up that joint. So I'll offer both the patients. Yeah. I'll say, look, we can compromise, but you have to understand that you may not get the best correction that you're looking for without using that joint and putting it in the cast.
Yeah.
At the upper right, you're obviously, you're trying to point out the MIS versions.
Yeah, the MIS. So the difference between, and this is one thing that, I pointed out in our previous episode, the difference between doing open versus MIS.
So
yes,
MIS is minimally incisional surgery.
Yeah. The benefit is obviously you don't have a long incision, which, it's 4 centimeters versus 3 1 centimeter incisions. I mean, it is what you want to make it. But the difference is when we're in there, we do a lateral release I do the adductor tendon transfer to make sure that bunion hopefully never comes back again. There's different things, even though the bunion end result, when you look at it from the top of your own foot without looking at the x-rays, it looks the same. There's a lot of different things that we do on the inside to make sure that you don't come back to us 10, 15 years later with a bunion and, hey, doc, what happened? Why is this bunion back?
And I think the MIS versions, you're asking a lot of that bone healing capacity.
Yeah.
And so you've really got to be very careful with your patient selection. I wouldn't do an MIS version on a 75-year-old patient and expect that their bone healing is going to bridge that gap that you can pretty clearly see.
Yeah, young, healthy adults, that can, hopefully heal bone without any risk factors adding to it.
Non-smokers, non-diabetic. I mean, that patient population clearly is out there, but we still see them that often.
Yeah.
I saw one today. I saw a perfectly healthy 29-year-old patient with a severe hypermobile bunion. We talked about her options. She had already done the research. She's like, look, I think I know I probably need a Lapidus. So it was easy to discuss it with her because she was pretty well informed. But non-smoker, not diabetic, kind of the perfect patient for doing a Lapidus.
So here's a person talking about the Lapidus that had a Lapidus procedure, and it looks like it was undercorrected. So whoever did the surgery was either undercorrected or when they did the surgery, it bounced back some. They probably didn't do a good lateral release, or the patient walked on it afterwards, which happens. I just had that, that lady with the Aiken that had the non-union.
Yeah, could have been maybe a little more aggressive Aiken. Yeah. They could have probably gotten a little more out of that.
But what they do, they go in, they find where they can go in and fix it. And like I said, there's a dozen different common bunion procedures. So they did the Lapidus. They got that hypermobility, which was probably evident in this first surgery taken care of. And they went in and did a distal Austin procedure and brought that bunion nice and straight. Looks like they fixed some hammer toes in conjunction with it. Yeah. But as far as surgery goes,
that's a great outcome.
Yeah, I think that outcome looks perfect.
Yeah, and they didn't need to do anything to the first metatarsal cuneiform joint, to that proximal site where there's the plate and the two screws.
So sometimes you'll also have hypermobility between here. So you'll see us put longer screws between here. It's a stepwise approach. When we talked about a bunion episode, you'll see what we talked about.
And all this stuff with the lesser metatarsals in that one. Go back one real quick. You get oftentimes transfer lesions where patients are having pain underneath the second metatarsal head with a very hypermobile bunion. And sometimes you don't have to address those initially.
If you bring it over and down, you bring it into a parallel plane, works out great.
You make that first metatarsal actually bear weight. Mm-hmm. But I don't disagree with doing a while or doing some sort of corrective procedure to realign the parabola. Although that parabola doesn't look that bad. Yeah,
but that's they did the while with that. So I'm assuming it was probably longer.
Yeah, but it looks like I guess they didn't do anything in this right hand picture. But look at the metatarsal head. It looks like it's been completely eroded.
Yeah.
So did that happen in the interim, or did they go in and remodel that with the second surgery? That's I'm not too sure about. Chicken and the egg. But
well, say you did a Austin Aiken bunionectomy and
didn't address the severe.
I mean, that looks like that was a good 15 plus degrees in general.
So the degrees we're talking about is the angle that you can draw between your first metatarsal and the second metatarsal. Yeah. So that angle is an important concept. Normal is 11, 12 degrees. When you start to see 15, 16, 17, 18 degree IM angles, it's really hard to get good correction, long-standing correction with an Austin Aiken. You really need to move that whole metatarsal over, and that's what the Lapidus is so powerful for.
They also derotate it. I mean, what we can see is like there's the shadow of the nail that's there, and it's rotated out. So that's the people that have the bunions, that have the nails, the toe sitting sideways.
Yep.
Right? Your foot looks like this, wrong way.
That's the true abductor valgus.
Yeah, it's rotated. So even if they brought that back in, the toe rotation hasn't been corrected. So they probably derotated this when they corrected that bunion.
I can guarantee you that was a hypermobile.
Oh yeah,
for sure. And so that was that choice of procedure was wrong.
Yeah.
Just straight out of the textbook. That was just the wrong procedure.
Yeah. Large IM, hypermobile, obviously rotated toe. I mean, you have to address all that. Now, when we talked about the parabola, this is probably one that may have a little metatarsalgia in the future, especially that second metatarsal.
Unless they brought that first ray down.
Unless they brought it down.
Yeah. If they brought it down sufficiently and it's bearing weight, the patient may never have an issue with it. But you're right. The parabola
compared to the previous.
Yeah, because you really lost some length to the first ray there.
Yeah.
But that's a good construct. I love their construct.
Yeah. Solid.
Yeah. And connecting it to the second ray, I don't think it's a bad idea because you get some instability between the first and second metatarsal bases.
Yeah.
So that will probably last the test of time. And that plate system can be removed once everything heals up if it becomes a problem.
Yeah. So here's all I wanted to talk about was metaductus. So these are two patients. I found these online, and I was like, well, this person kind of has a metaductus because I saw this X-ray, and I was like, that looks very similar to what their foot structure is. You can only shift this over so much, you know.
Right.
There's another bone there. So the ideal way to fix this would be to correct the metaductus like they did here. And this one looks great.
So they tried to do a Jabara.
Yeah.
With the upper left. So that's an osteotomy in the base and proximal shaft of the metatarsal where you're trying to take out a wedge of bone, close that wedge down, and move the entire metatarsal over. Is the bottom one a pre-op?
I think these are two separate patients.
Two separate patients.
Yeah.
Okay, gotcha. I don't know that they made much of a difference in the IM angle with that procedure, and that's largely why I don't think that's helpful.
Yeah,
I don't even do those base wedges anymore.
Most people have
used the joint.
Yeah, most people have phased away from it because the Javara and the Lapidus or met cuneiform base arthrodesis, its patient population is the same, right? The only caveat to that is the hypermobility, which most people who have a large bunion typically have hypermobile.
Yeah, so you still have to put people in casts for that. Yeah. Most likely you're going to keep them on weight bearing. So
6 weeks.
Why would you diminish the long-term effectiveness of the surgery?
And you don't have that rotational benefit either.
Correct. You can't really change that. And you can see, the sesamoids are rotated out.
Yeah, this one for sure. This one looks great. This one, whoever did this, looks beautiful.
Yeah, that's a classic correction.
All right, this I couldn't find any good pictures, but I've seen these in the past where a patient has a Austin Aiken type of procedure, and they end up having just a small residual bunion, and it's mostly at the hallux interphalangeal axes. What's that called?
So they've got hallux interphalangeus.
Yeah.
So the curvature is really just in the toe.
Yeah, not in the bone here, but just in the toe. Right. So you can go back and, literally do a parallel cut, replace that joint. You can do an Aiken also, but a lot of these are arthritic, so the hemi implants tend to work pretty well for these.
I love the far right one. That simple hemi, that construct, that particular design has been around for about 65 years.
Yeah.
So there are literally people, well, they may not be walking the earth any longer, but there are literally people who had that put in and walked relatively pain-free for the rest of their lives because that implant has no plastic component. It's usually chromium cobalt.
Press fit, no bone healing.
There's nothing about it that's going to ever wear out. I would say the only thing you have to counsel people on is there can be, they already had a stiff joint most likely, so they may not have normal range of motion, but they want some range of motion as opposed to a fusion. I think those are great. They're stupid proof. They're so easy to put in. I've had to take one out in 25 years of using them. And that one that I had to take out was because the patient fractured the bone around the implant. And it literally basically fell out of the foot.
Yeah.
Those things are so stable. I'm not a huge fan, obviously, of the two.
Yeah, it's not something we see too often.
Yeah, those really fell out of favor. One of my attendings at St. Louis took over the practice of a guy who invented a 2-component implant. And he was, unfortunately, the previous guy was slapping him and everybody. And so my attending in my residency was having to deal with all the repercussions and the bad outcomes from this 2-component implant. It's really difficult to replicate the great toe joint range of motion. It's a moving center of range of motion.
Yeah.
And so trying to replicate that with a two component implant is really difficult. They generally have failed and not been real happy with them. Silastic implants, I don't know, do you even do those?
No, I don't do those. I used to do Kellers here and there. I've just gone to the hemi implant. So Kellers, where we put the little, spacer in between their soft tissue spacer.
Yeah.
Take the base off.
You got the hemi implant. Why would you do a Keller? I mean,
Yeah.
it's essentially a Keller with an implant, right?
Yeah,
So
honestly.
the far left one, I think those head procedures became quite popular a few years ago. It's more dissection. That piece tends to grind into the base of the toe, and you get remodeling around it, and that can cause problems. Some people don't get the pain relief they were expecting. So I just really don't like them, and I don't use them.
You have to have the right patient for it. And obviously, we're talking about for revision bunions. So you have to think there's hardware there. There's going to be screws here sometimes. You have to take those screws out. You're weakening the bone on that aspect.
Right.
A lot of the times for revision bunions, you'll see something along the lines of this, where you go in, they had the screws and the lapidus or whatever they had in the past, and they just have to go back and clean up the joint because those subluxed are angled for so long.
The beauty of that right hand hemi implant is that it really doesn't matter a whole lot what the metatarsal head looks like at the end.
Yeah.
It could be a gnarled, ugly looking first metatarsal head with no cartilage. As long as the metatarsal head is rocking back and forth in that smooth metallic surface, there's no grinding, there's no pain. So those things are underutilized, I think, in general orthopedics, and probably should be used more because of how
successful they are.
How easy they are to put in.
All right. The end-all, be-all. So you had bunion surgery, and it blew up on you, right?
Well, or just you got 10, 15 years down the line and the joint kept breaking down.
Yeah.
I mean, that's the thing we can't prevent. We can't necessarily prevent the progression of osteoarthritis in that joint that got put in motion by the fact that you had a severe deformity for years before you had the bunion, most likely.
Yeah.
Most people don't get these fixed when they're in their 20s. They usually wait until they're in their 30s.
Yeah. Oh, my toe's crossing over now. I want to get this fixed.
Yeah.
So, anyways, we can do a fusion, an arthrodesis of the joint. They work out great. It's the end-all, be-all, tried true, works out really, really well. People always worry about the lack of motion. Yes, you lose some motion there, but it's not a big loss, honestly. It's real straightforward. Plates, screws, staples, whatever your doc prefers to use. They all work out really, really well. And yeah, you're walking, in normal shoes without any pain. No joint, no pain.
Yeah, once it's healed, but you're still.
After 6 weeks is no pressure. Yeah.
So non-weight bearing in a cast, can boot, because the lever arm there is significant, and if you have motion, you're going to get a non-union. So but the plate and screw systems we have access to now are stout, and they make this procedure
super easy,
really, really fairly easy and reproducible, extremely reproducible. So, patients don't want to hear fusion. They don't want to hear I'm not going to have motion there anymore. But there are times when this is the only way to correct the deformity when you're doing a redo.
Yeah.
And so I agree with you. These can be really valuable.
Yeah. I mean, it is what it is. You have the options available to you. Your doc can talk to you about the options. It just depends on each individual case, because it depends on what hardware is there, how much of an angular deformity you have, what the rest of your foot looks like,
what your bone stock looks like. Like if you had severe osteopenia, osteoporosis, a fusion may not be a good choice.
It wouldn't
you might
hold.
be better off with a hemi implant and just keep your fingers crossed that the bone around the hemi remains intact. But so there's all kinds of things that we have to consider when we're talking to patients about choice of procedure. And if you run into a surgeon who only fixes bunions one way, I would keep shopping.
Yeah.
If everything they do is the same scarf bunionectomy, you can't fix every bunion with a scarf. You can't fix every bunion with an Austin Aiken or a Youngswick Aiken.
Yeah.
So, make sure that your bunion surgeon, whether they're an orthopedic surgeon or a podiatric surgeon, has an affinity for the procedure, does 20 or 30 or 40 or 50 of them a year, and then has access to multiple procedure options, because you just can't fix them all the same way.
Yeah. Well, that's pretty much it.
Do we have any other questions from that subscriber that we didn't answer?
Age of patient, complications, plantar plate tear, Morton's neuroma.
Okay, so these are the things. Some of the things I think she was questioning, and you can just mention her first name. Just so you give her credit.
Say Christy.
Well, Christy sent us this a few weeks ago. Morton's neuromas are not directly related to bunions, but if you have a very hypermobile forefoot where there's lots of motion, that seems to be the foot structure where patients can develop interdigital neuritis or Morton's neuroma.
Bunions deviated over, you're wearing shoes that squeeze your toes together, mobility, you're pinching that off. It's a
and so that's a separate discussion. We have shows on neuroma where we're looking at decompression versus neurectomy. We clearly recommend decompression or releasing the ligament by far before you end up considering having the nerve removed. The nerve removal is only necessary about 5 to 10% of the time.
Yeah.
And so again, that's another situation where if your surgeon only has one option,
you have a normal, you guys size it.
Excision. If you do a couple of steroid shots and it doesn't get better and they want to cut it out, I would find another doc, honestly.
The plantar plate tears, that's true with bunions.
Yeah, that can happen with direct mechanical problem with bunions. Yeah.
It's a overstress of that joint there. It's the hammer toe effect, because that first metatarsal is hypermobile. It's shifted over. The second metatarsal is now bearing the brunt of the pressure. The foot is trying to grip the ground, we like to say, and you get that hypermobility and that instability, which puts stress on that second metatarsal, drifting that toe up. Plantar plate tear along the second. Usually it'll start drifting over medially towards the big toe joint. Yep.
And we have shows on that as well.
You can address that all in one surgery.
Yeah.
It's not something you have to space out typically.
And these are sequela of the main problem.
Yeah.
When you're talking the plantar plate tears and hammer toes.
How many times have you had a patient come with hammer toes? You're like, I got to fix hammer toes, but I got to also fix the bunion. And like, the bunion doesn't bother me.
Yeah.
Well,
like you got to move the big toe out of the way. It is the bully that's causing your other deformity. So, yeah, that's a discussion that people need to understand. And then also, simply correcting just the second one can lead to worsening of 3 through 5 because it's a joint extensor tendon. So your extensors are one tendon at the ankle level. You fix the second toe, and then the third, fourth, and fifth end up really contracting because now you're adding all this load onto the main extensor, which is now directing all that force into the third, fourth, and fifth toes. So sometimes it does make sense to fix all 5 toes at once because of some of those issues.
And typically, honestly, when people come in with a plantar plate injury, their hammer toe for the second is extreme, but they also have hammer toes at the other toes too.
They do. So it just may not be as big an issue, but
yeah,
correcting those is not. I don't think that's unrealistic or unreasonable to do. Well, awesome. Well, Christy, I hope we answered some of those questions. Again, we do have shows on hammer toes. We have shows on plantar plate tear. So if you're concerned about those issues, you can go back to those and review those. I think this was a great discussion about redo bunions. They happen, but generally speaking, it's a misfire on the choice of bunionectomy usually. But again, you get 10, 15 years down the line, your joint can continue to break down, and so that's where you end up with a different problem, which is osteoarthritis at your first metatarsal phalangeal joint, sometimes called hallux rigidus. And we have shows on hallux rigidus, so take a look at those too. Welcome to season 5. This is the second episode in season 5 in 2024. Today is Eclipse Day.
Yeah. We
are almost in the path of totality here in Denton, Texas. Not quite. You got your glasses? Yeah, I got mine. Yeah, hopefully everybody has glasses so they don't injure their retinas. But enjoy Total Eclipse Day because we won't have another one for 20 years.
Wow.
And we will see you next time on
PODdoctors.
the PODdoctors. Bye-bye.